breast cancer, treatment options for breast cancer, Part 2. This video will include treatment options for breast cancer, for both hormone-positive and hormone-negative breast cancer, TNBC. Initial part of this video will be on chemotherapy and other management of breast cancer. Second half of the video will cover the recent treatment updates on triple-negative breast cancer, TNBC. Breast cancer treatment options includes chemotherapy, surgery, radiotherapy, targeted therapy such as anti-Her2 receptor, immunotherapy, and oral hormone therapy, depends on breast cancer stage and hormone receptor status. I will discuss about chemotherapy treatment options initially. Chemotherapy for breast cancer. Chemotherapy uses anti-cancer drugs that may be given intravenously or by mouth. The drugs travel through the bloodstream to reach cancer cells in most parts of the body. Occasionally, chemo may be given directly into the spinal fluid which surrounds the brain and spinal cord. When is chemotherapy used for breast cancer? Not all women or men with breast cancer will need chemo, but there are several situations in which chemo may be recommended. After surgery, adjuvant chemotherapy. Adjuvant chemo might be given to try to kill any cancer cells that might have been left behind or have spread but can't be seen, even on imaging tests. If these cells were allowed to grow, they could form new tumors in other places in the body. Adjuvant chemo can lower the risk of breast cancer coming back. 2. Before surgery, neoadjuvant chemotherapy. Neoadjuvant chemotherapy might be given to try to shrink the tumor so it can be removed with less extensive surgery. Because of this, neoadjuvant chemo is often used to treat cancers that are too big to be removed by surgery when first diagnosed, called locally advanced cancers. For advanced breast cancer, chemo can be used as the main treatment for women whose cancer has spread outside the breast and underarm area, either when it is diagnosed or after initial treatments. Sometimes it is not clear if chemotherapy will be helpful. There are tests available, such as Oncotype DX, that can help determine which women will most likely benefit from chemo after breast surgery. Chemotherapy drugs used for breast cancer. 1. Adjuvant and neoadjuvant drugs. A. Anthracyclines, such as doxorubicin, adriamycin, and epirubicin. B. Taxanes, such as paclitaxel and docetaxel. Circa 5-fluorouracil or capecitabine, cyclophosphamide, carboplatin, etc. Most often, combinations of 2 or 3 of these drugs are used. 2. Drugs for breast cancer that has spread, advanced breast cancer. Taxanes, such as paclitaxel, docetaxel, and albumin-bound paclitaxel. B. Anthracyclines such as doxorubicin, pegylated liposomal doxorubicin, and epirubicin. C. Platinum agents such as cisplatin, carboplatin. 4. Vinorelbine, 5. Capecitabine, 6. Gemcitabine, 7. Ixabepilone, 8. Eribulin. Although drug combinations are often used to treat early breast cancer, advanced breast cancer more often is treated with single chemo drugs. Still, some combinations, such as paclitaxel plus gemcitabine, are commonly used to treat advanced breast cancer. How is chemotherapy given? Chemotherapy drugs for breast cancer are typically given into a vein, either as an injection over a few minutes or as an infusion over a longer period of time. This can be done in a doctor's office, infusion center, or in a hospital setting. Adjuvant and neoadjuvant chemotherapy is often given for a total of 3 to 6 months, depending on the drugs used. The length of treatment for advanced breast cancer depends on how well it is working and what side effects you have. What is dose-dense chemotherapy? Doctors have found that giving the cycles of certain chemo drugs closer together can lower the chance that the cancer will come back, and improve survival for some women. For example, a drug that would normally be given every 3 weeks, might be given every 2 weeks. This can be done for both neoadjuvant and adjuvant treatment settings. It can lead to more problems with low blood cell counts, so it's not an option for all women. A chemo combination sometimes given this way is doxorubicin, adriamycin, and cyclophosphamide, followed by weekly paclitaxel. Possible side effects of chemotherapy for breast cancer. Hair loss, nail changes, mouth sores, loss of appetite or weight changes, nausea and vomiting, diarrhea. Chemo can also affect the blood-forming cells of the bone marrow, which can lead to increased chance of infections, from low white blood cell counts, easy bruising or bleeding, from low blood platelet counts, fatigue, from low red blood cell counts and other reasons. These side effects usually go away after treatment is finished. There are often ways to lessen these side effects. For example, drugs can be given to help prevent or reduce nausea and vomiting. Menstrual changes and fertility issues. For younger women, changes in menstrual periods are a common side effect of chemo. Premature menopause, not having any more menstrual periods, and infertility, not being able to become pregnant, may occur and may be permanent. Some chemo drugs are more likely to cause this than others. The older a woman is when she gets chemotherapy, the more likely it is that she will go through menopause or become infertile as a result. Heart damage, nerve damage, neuropathy, hand-foot syndrome, chemo brain, increased risk of leukemia, feeling unwell or tired, fatigue. Next video will be on recent updates on triple-negative breast cancer in second section of this video. Recent treatment updates on triple-negative breast cancer, TNBC. Triple-negative breast cancer, TNBC, is a term that has historically been applied to cancers that lack expression of the estrogen receptor, ER, progesterone receptor, PR, and human epidermal growth factor receptor 2, Her2. TNBC tends to behave more aggressively than other types of breast cancer. TNBC accounts for approximately 15% of breast cancers diagnosed worldwide, which amounts to almost 200,000 cases each year, compared with hormone receptor-positive breast cancer. TNBC is more commonly diagnosed in women younger than 40 years. Risk factors associated with the diagnosis of TNBC includes positive BRCA mutation status, 2. Race, 3. Premenopausal status, 4. Obesity and a young age of first pregnancy, with an increased risk of TNBC. Clinical presentation, TNBCs present with rapid growth, and are more likely to be diagnosed clinically, rather than mammographically than ER-positive cancers. TNBC is usually high-grade, and the most common histology is infiltrating ductal carcinoma. Although a rare histologic subtype, medullary carcinoma, is generally triple-negative. The triple-negative breast cancer has 5 clinical phenotype, mostly comprises the basal-like molecular subtype. Genetic evaluation, the BRCA gene mutation testing, association of particular breast cancer susceptibility gene 1, BRCA1, mutations with TNBC. Treatment options for TNBC. For non-metastatic disease. The neoadjuvant or adjuvant chemotherapy options, for patients with TNBC are similar to the approaches used in other breast cancer phenotypes. The principles for the surgical management and radiation therapy options for breast cancer are also applied in a similar way across breast cancer subtypes. One. Chemotherapy. Chemotherapy is recommended for women with TNBC greater than 0.5 centimeter or with node-positive TNBC, regardless of tumor size. These patients have a higher risk of relapse compared with other breast cancer phenotypes and are not candidates for other forms of targeted therapy, such as HER2-directed treatment or endocrine therapy. Preferred regimen for NACT, anthracycline, alkylator, and taxane-based chemotherapy regimens remain the standard regimens for TNBC. For example, docetaxel and cyclophosphamide followed by paclitaxel, ACT. Taxanes have significant activity in the treatment of TNBC, and there are no meaningful data regarding regimens lacking alkylator-based therapy. Benefits of chemotherapy. Stage for stage, there is a larger absolute benefit to neoadjuvant/adjuvant chemotherapy among patients with TNBC compared with those with hormone-positive disease. A larger reduction in the risk of recurrence, 55 versus 26%. This translated into a higher absolute improvement in DFS, 23 versus 7%. A larger reduction in the risk of death, 55 versus 23%. This translated into a higher absolute improvement in overall survival, OS, 17 versus 4%. These data emphasize the importance of neo/adjuvant chemotherapy for women with TNBC who are not eligible for targeted therapies like HER2-positive patient. Surgical management for TNBC. The principles for the surgical management options for breast cancer are also applied in a similar way across breast cancer subtypes. Treatment of tumors less than or equal to 0.5 centimeter. The prognosis of node-negative, triple-negative tumors less than or equal to 0.5 centimeter is generally favorable, and therefore, the benefits of adjuvant chemotherapy are likely to be very small and must be weighed against the chances of serious side effects of chemotherapy. In general, patients with microinvasive or very small, 1 to 5 mm, tumors do not need chemotherapy. What will be the next steps to proceed? repeat biopsy followed by reassessment of ER, PR, and HER2. This is because there is a possible discordance of these markers between primary and metastatic disease. B. PD-L1 expression. C. TMB, MSI, and dMMR. Treatment approach for metastatic/recurrent disease. For no germline BRCA mutation and PD-L1 negative tumors, triple-negative metastatic breast cancer, that does not express programmed cell death ligand 1, PD-L1, is to use single-agent chemotherapy. However, combination chemotherapy strategies may be appropriate in some such patients with rapidly progressive visceral disease. For PD-L1 positive tumors, for those with tumor expression of programmed cell death ligand 1, PD-L1, recommend the addition of an immune checkpoint inhibitor to chemotherapy, rather than chemotherapy alone, such as 1. Atezolizumab, 840 mg D1, D15 and nab-paclitaxel, 100 mg/M2 D1 D8 D15 in 28 days interval. 2. Pembrolizumab 3. Eribulin plus pembrolizumab. Treatment dose: Eribulin 1.4 mg/M2 on days 1 and 8 plus pembrolizumab 200 mg on day 1 of each 21-day cycle. Enhance 1 phase 2 study. Germline BRCA mutation present. For most patients with TNBC with germline BRCA mutations, who have previously been treated with chemotherapy, in the neoadjuvant, adjuvant, or metastatic disease setting, suggest an oral inhibitor of PARP, such as olaparib/tilazoparib/veliparib, rather than chemotherapy. Later line treatment option. 1. Sacituzumab govitecan. Sacituzumab govitecan is an antibody-drug conjugate that targets TROP2 for the selective delivery of SN38, the active metabolite of irinotecan. It is approved by the FDA for the treatment of adult patients with unresectable locally advanced metastatic TNBCL, who have received at least 2 prior therapies, at least one of them for metastatic disease. Pembrolizumab for tumors with high TMB or MSIH/dMMR tumors. Prognosis of TNBC. The risk of distant recurrence and death peaks approximately 3 years after diagnosis and declines rapidly thereafter. Furthermore, However, TNBC may be more likely to recur in loco-regional areas, as well as in visceral organs, such as liver, lung, and brain involvement at first recurrence. By contrast, TNBC is less likely than ER-positive breast cancer to recur initially in bone. Thank you for your kind watching. Please subscribe, like and share my channel.